Hi everyone, myself Dr. Priyanka and I'm one of your mentors for study MRCPI. So today we are back with the YouTube series and we'll be discussing on maternal medicine module. And here we'll be discussing few important uh, frequently asked questions from the module. So let's start. So always remember that never put a limit on what you can do. So there is no limit and you can definitely win if you believe in yourself. Now coming to questions, so here we are going to discuss the single best answers. So we will be discussing the question followed by the answer with the explanation. So the first question is, there is a 34-year-old woman. She is in her third pregnancy and she attends the antenatal clinic at 36 weeks for a labor plan. Okay. She tells you that she is on beta blocker as she suffered from rheumatic heart disease as a child. Which of the following therapies should she avoid in the second stage of labor? So she is a known case of rheumatic heart disease and she is taking a beta blocker and she has come for the labor plan at 36 weeks. So what is the thing that you are going to avoid in her case? So it's the answer is the B, that is intravenous ergometrin. So ergometrin, that is the methergine, it is usually avoided in patients who are hypertensive or who suffer from cardiac disease uh, because of the increased risk of going into like hypertension, going into crisis and also going into cardiac failure. So that's why it is avoided in patients with ergometrin. And rheumatic heart disease, we know that it is most commonly associated with mitral stenosis. And in mitral stenosis, there is tachycardia, which is there because of the fixed cardiac output. And the patients with mitral stenosis, so they are more prone to develop, to go into pulmonary edema and hence into cardiac failure. So the risk is already high in them. And if we give intravenous ergometrin, so the risk, it has an added effect. So that's why that is the reason we are going to avoid intravenous ergometrin in patients with rheumatic heart disease. Yeah, so that because they have 35% of the cases that will be accompanied by mitral stenosis and they are at risk of having pulmonary edema and hence cardiac failure due to autotransfusion after the delivery, hence it is avoided. Now the question is, you are reviewing the notes of a 32-year-old woman and she is 10 weeks pregnant from her last period date and she is in third pregnancy. So she has two sons who are aged 4 and 2 years and they are fit and healthy. There are no other risk factors for gestational diabetes. So in which of the following conditions you are not going to offer her screening for gestational diabetes? So the screening for gestational diabetes, according to the RCPI guideline, that it is done to specific population who are at increased risk. Okay, so it's a selective screening for whom, for those who are having a body mass index of 30 kilograms per meter square, and also those who have a family history. So these are the class of people who are at increased risk of developing gestational diabetes mellitus in pregnancy. So if there is a family history, so of course we know that that is also going to increase the risk and hence we are going to screen them. If there is a family origin of high prevalence of diabetes, or if there is a high risk ethnicity group, or if there is a previous history of macrosomic baby who weighed more than 4.5 kilos. So these are the reasons where we are going to screen them. Or if there is a history of previous GDM, if there is history of previous stillbirth, or we said like a previous macrosomia. So these are the some few reasons where, or if the previous pregnancy was complicated by shoulder dystocia. So these are the reasons where we are going to, risk factors where we are going to screen her in this pregnancy. But if she's already a case of previous type 2 diabetes, that is option E, means that she doesn't need screening. She is already a case of previous pre-gestational diabetes in which we are not going to screen for her. So it will be she will be treated as a pre-gestational diabetic patient and will not require any screening for GDM. So as I said, whom should we check for the screening? If they have a BMI more than 30, previous macrosomic baby weighing more than 4.5 kilos, previous GDM, previous history of family history of diabetes, or a family history of high prevalence of diabetes, that is high risk ethnic group like South Asian, Indian, Pakistani, Bangladeshi, Black, Caribbean, etc. Now there is a primary gravida who is 32 weeks pregnant and she is diagnosed to have GDM on her 28 weeks OGT. So far, she has tried diet, exercise, and even OHS, that is metformin. Her plasma glucose values are still not within the target range, so it's uncontrollable GDM. She declines insulin therapy because she is needle phobic. So, which of the following treatment options are best suited to her? So if we cannot give insulin in her case, and if it is not controlled by metformin, then here the option is, and also not by diet and exercise, the next option we can give is option D, that is sulfonylureas. So that is we can give glibenclamide for women who have gestational diabetes, in whom the target is not achieved with metformin, and also who decline insulin therapy. Now there is a pregnant woman with epilepsy. So when she has the highest risk of breakthrough seizures, okay. So is it in the first trimester, intrapartum, postpartum, second trimester, third trimester? So the highest risk of seizures is when she is in the postpartum period, that is option C. Why? Because in the postpartum period, there is change in the concentration of the AEDs in the blood, and also there are some risk factors which can trigger. We can say more better word is the triggering factors which can increase the risk of seizures, like if there is a lack of sleep, and also the patients have to take care of the babies, and uh, these reasons can increase. There is decreased compliance because the mother may feel that through breast milk it can affect the baby, and because of these reasons they may stop taking their anti-epileptic drugs, and because of lack of sleep, so this can trigger the development of seizures. And other factors are the hormonal changes that happen in the postpartum period, so they can also increase the risk, and that's why the postpartum period is considered as the highest risk of developing the epileptic seizures, and that is the reason where one-to-one support or family support is very important for these patients, and they should provide support to the patient in taking care of the baby. Also, there are some options like not bathing the baby alone, or not sleeping alone with the baby, or having shallow baths for the baby. So these are the measures that can be taken to prevent any injury to the baby. Now, Mrs. XY is a primary gravida who is 30 weeks pregnant, and she comes to accident and emergency with acute onset of shortness of breath and chest pain. So she has just traveled via long haul flight, that is almost 12 hours to the UK. So which of the following investigations is not appropriate in the investigation of a suspected P in pregnancy? So if there is a suspected pulmonary embolism, so it can present with shortness of breath, cough, or a pink frothy sputum. So these can be the symptoms which can develop, and there can be sometimes some risk factors like this patient has of traveling through a long haul flight. If there is a suspicion of pulmonary embolism, what is the investigation that we won't do? Is the question. So CTPA, that is pulmonary angiography, is done in pregnancy when there is when first investigation that we do is a uh, chest X-ray. If the chest X-ray comes abnormal, we do a CTPA in if we have suspicion of pulmonary embolism. So CTPA chest X-ray are done. D-dimer is usually not done in pregnancy is the correct answer, because D-dimer levels normally increase throughout the pregnancy, and they are more abnormally high in third trimester. So they are not specific in diagnosing pulmonary embolism. So these are not done. ECG is also done in pregnancy, and ventilation perfusion scan, that is VQ scan, is also done if the chest X-ray comes normal. So the answer here correct is D dimer levels, because their value is normally increased in normal pregnancies, and especially high in multiple pregnancies. So here is the algorithm. So if there is a suspicion of P in pregnancy, we look for any associated leg symptoms. If they are absent, we do a chest X-ray. If they are present, we do a compression ultrasound. And if it's positive, we treat. If we do a chest X-ray, it comes normal, we do a ventilation perfusion scan. If the ventilation perfusion scan comes negative, we stop the prophylactic treatment. If it comes positive, we give the therapeutic treatment by therapeutic method of thromboprophylaxis. If the chest X-ray is abnormal, we do a CTPA, that is CT pulmonary angiography. If it's negative and there is low suspicion, we stop the treatment. If it is technically inadequate, we do a compression ultrasound. And if it's positive, we give the therapeutic dose of thromboprophylaxis. So thank you guys for attending. I hope this helps. Thank you so much.